There we go. Thank you all again. Nice to be back up in front of you. I brought my my clock, phone, camera, whatever. I brought my phone so I can time myself this time, so I won't go over. Okay. So yesterday I gave you my context. Today I'm going to give you a little bit different part of my context, or my frame of reference. So one of the national leadership positions that I'm in is on the accreditation committee for the Public Health Accreditation Board. The Public Health Accreditation Board, or FAB as we call it, is the body that accredits local, state, territorial health departments and tries to assure that public health practice is done and it meets a certain minimum standard. And the FAB accreditation folks will tell you that what they put down on their accreditation standards and measures is not best practice, it's minimum practice, right? So this is the standard by which health departments should be operating. I don't have the numbers in front of me, but I believe I'll guess conservatively and say I know it's more than 90% of the U.S. population is being served by FAB accredited health departments. But the corollary to that is that those are usually the larger health departments in larger cities and communities, and so they serve a greater proportion of the population as a whole. So of the 3,000 plus local, state, and territorial health departments in the U.S., I don't even know if it's a majority of them are actually FAB accredited. So, we have more work to do in terms of getting health departments accredited, but most of the population is served by accredited health departments. Give you a second on that one if you need it. Okay. So yeah. So anyway, familiar with those standards and measures. The body I'm on reviews health departments' applications for accreditation and goes through all of those different standards and measures to see if they are demonstrating them at a satisfactory level. So that's the frame of reference for this conversation. So I want to talk about it again, as I did yesterday, start off with defining a couple of different terms or concepts. First, a local health department. This actually applies to state health departments as well. They're government entities with responsibility for promoting and protecting the health and environment within their jurisdiction. Some version of that will be virtually every health department's mission statement. It'll be in there somehow, right? Some different order, or they may have an add-on to that, but that's in there. As I said, we do have more than 3,000 health departments in the U.S. alone. And even though we have that many different health departments, there are some striking similarities across health departments. Typically, a health department will at the very least have an environmental health unit that not only addresses environmental sort of writ large issues, maybe things like climate change, but they will also address, and I think the comment was made yesterday about public health departments wanting to inspect your septic systems and your private wells and all of that, all your restaurants, frankly, even the food sold at gas stations, even if it's prepackaged, right? Health departments do all of that. But there's almost always, whether it's the nursing division or a population health division or a community health division or a health promotion division, there's that group of professionals at the health department who are typically either trained public health nurses or they're health educators, or there's a combination of all of those. And those are the folks that are actually doing that community outreach in terms of providing guidance to the public that they serve in terms of how to be healthy. There's another piece that since 9/11, way back when, that's added into the public health domain in terms of the work we do, and that's emergency preparedness. That became a very big piece of what we do. I remember sitting in my office as an epidemiologist in Akron and watching the planes hit, and then the anthrax issues that came right after forever changed public health in terms of adding that element of our work. Another common feature of public health work at the governmental health department level is that process of assessing your community, assessing the needs, assessing the resources. It's not just the problems, but what resources do we have? Understanding the population we serve, understanding the environment in which we serve that population. Then we plan all right? There's no point in assessing and not doing anything with it. Folks often forget that part of the definition of surveillance is the collection of data, but also using that data to enact change. So we assess, we plan, we do, right? If you're going to plan, you better do. We measure the impact. Sometimes we just think of that as the next assessment, and rinse and repeat. Just sort of go through that cycle. And as I said yesterday, all of the work we do relies on community partners and public input. All of those things that I just talked about are going to show up in FAB standards and measures for accreditation. Let me tell you a little bit more about Special Olympics International, because that's actually the hat I'm wearing now. I mean, I still have, I think, the hat hair for my public health hat at the governmental public health, well, such as it is. But yeah, putting on the Special Olympics hat. It's a non-governmental, nonprofit international organization. It describes itself as a movement for inclusion of people with intellectual and developmental disabilities through sport and competition. And that's been a challenge for me because I am not a sport guy. I usually have to have most of the athletic events explained to me a little bit better. I understand them. I watch, football, basketball, baseball, but that's about the extent of my sportiness. But that's central to the mission of Special Olympics. All right, but especially in North America and very specifically in the United States, we do an awful lot of work beyond that. Through federally funded agencies. We have the Unified Champion Schools department, if you will, within Special Olympics North America, funded by the Department of Education, and that's where we do an awful lot of work with school systems around the country, where it's just the focus is on inclusion. It really is, and the bilateral value, the bilateral benefit of integration with folks neurotypical and not neurotypical, so that interaction is really at the basis of inclusion and normalization and stigma reduction and all of that. So that's a big piece of what we do. That's a huge hunk of the funding that we get in Special Olympics North America. The other is the major focus on health, and we're currently in year 4 of a 5-year cooperative agreement with the CDC. The CDC does fund Special Olympics International, recognizing that CDC funds must be focused on the U.S. And so while it goes through our headquarters, it's administered through Special Olympics North America, given that all of the U.S. programs are served by Special Olympics North America. We get funding, it's right in the range of about $18 million a year. Which is really nice. I mean, that was a nice change coming from governmental public health to Special Olympics International. I oftentimes describe governmental public health as begging for crumbs and then asking permission to eat them. So we're in a little bit different situation now. The CDC is very welcoming of the work we do. It's funded out of a division of the CDC that it focuses on the disabilities as opposed to the public health system. And so introducing a lot of the work that governmental public health does to that division within CDC has given them great excitement. So I think we have a promising future. As long as we have a CDC, that we will have CDC funding for the work we do in health. Special Olympics International is a federated model, and for those not familiar with that term, that means that you have a central agency, but that all of your other affiliated agency are their own agencies. They're all 501c3 programs in the U.S. They're independent agencies. Obviously, there are memoranda of understanding in terms of the use of the name Special Olympics. You can't be a Special Olympics program all by yourself. You have to, stay within the guardrails of Special Olympics International. But it's a a mutual relationship. It's sort of like the conversation we had yesterday with community partners. It's bilateral, it's transactional. We need to, and I keep impressing on the headquarters folks, we need to listen to the state programs in terms of what it is that they're interested in doing. When we have programs that come out of headquarters, it's important that we, apply the principles of inclusion, that motto of nothing about us without us. That applies to state programs when we're having conversations within Special Olympics. Some of the program we do is not palatable in some states. Most of what we do is generally acceptable across the board, but we do try to make sure that we're actually, one of my roles is to make sure that the headquarters is listening to the needs and the preferences of the state programs, and that the dollars that we sub-award out from that CDC grant to programs is done so in a way that's strategically compatible with the work they're doing. Obviously, it's standardized, so it's not always the case, but we do the best we can to have that balance. Our health work goes across 4 different pillars, and I think historically you watch the language, it used to be buckets and now it's pillars, and we all still talk about not having silos, but that's what all of those things mean. It's just how we organize the work. We have it across prevention, assessment, training, and health systems. Or PATH is the acronym they use, and as is the case often with Special Olympics speak, we get very alliterative. Prevention is our pillar 1, and that's the work we do in health education. So our family health forums that Special Olympics state programs do, that's part of pillar 1. Young athletes, which is another program that happens in Special Olympics, that's pillar 1. This is the prevention work. Then we have assessment, and this is includes a program that I think most folks are aware within Special Olympics, our Healthy Athletes program, and that's where we do the screenings at events where folks will come, and we have 9 different disciplines that are used for screening, everything from podiatry to optometry to dentistry. We do screenings at events. Not every state program can do all of those because it's a challenge to identify clinical directors who can provide those screenings because of their own lack of training of how to work with folks with intellectual and developmental disabilities. So that's another piece we're working on tied to that, right, is training professionals. We've also learned that there's not a whole lot that makes sense about screening somebody and then not connecting them with the clinical services that they need. Fortunately, not everybody that gets screened has an urgent need for that clinical care. We do have and recognize that we have a selection bias in terms of the folks that participate in Special Olympics are not living the same lived experience that folks who aren't, right? I mean, it's one of those things that's it's an extra activity that folks can do, and that takes planning at home, that takes resources to be able to get to training and athletic events and so forth, and not everybody has that same ability to do that. So we do have a selection bias, and I think that rolls over into access to health care for athletes as well. That said, a lot of our athletes that do get screened do need access to care, and so we're also working on trying to make sure that we have a care connection piece, and that's some of that work as well. Training clinical providers is another big piece. That's our 3rd pillar, where we're working with folks who, the academic institutions who prepare clinicians across all of those disciplines. And then finally, health systems. And this is the one that excites me the most because it's the one that's most tied to public health and really tied to the conversation today about community health assessments. And sorry, trying to give myself a little time check. Okay, that's tied to this idea of having inclusive community health assessments and community health improvement plans. So let's talk about what those are. Yes. Yes.
I wondered if you were as excited as I was to see the MMWR from the Centers for Disease Control and Prevention and their new program evaluation framework about emphasizing more contextual assessment and inclusion of accessibility in reviewing programs.
It sounds very exciting, but I'm not even familiar with it.
I'm going to forward it to you.
Please do that.
Yeah, appreciate that.
No, thank you. Yeah, not even on my radar.
Yeah, more, if people remember Lindsay's slide with the different terrain.
Yeah.
Right? We used to just assess how the person was doing and whether or not our program, maybe we assessed whether it fit their needs, but we rarely assessed the context in which the person needed to apply what we were teaching. So MMWR CDC just made some really important updates.
Thank you very much.
Yep.
Please do forward it to me.
Will do.
I appreciate that. So yeah, the Public Health Accreditation Board, I'm going to do this quickly because I think I've already mentioned this. Again, non-governmental, non-accrediting body for local, state, territorial public health departments. They do have those practice standards. Now, you saw the slide yesterday that had the 10 essential services. The practice standards within FAB are tied to that, and which include the essential services of community health assessments and community health improvement plans. So I'm trying to tie this as much as I can to public health accreditation because, again, just saying that we need to have intentionally inclusive or CHAs and CHIPs that are intentionally inclusive of people with intellectual and developmental disabilities isn't going to make it happen. But if we can tie it to the lever that we pull to move public health forward, then I think we have a chance to do that. So that's one of the sort of asides I'm trying to do in serving on that board. The 10 essential service, I won't spend too much time on this either, but again, thinking about all of those essential services and how they're not really there until they're intentionally inclusive of people with intellectual disabilities, because they are an element of every one of these. Another way that this is graphically represented, and this is newer in public health, let's say newer, let's say within the last 5 years, talking about foundational areas and foundational capabilities. And if you take a look at those foundational capabilities of governmental public health, you see where this idea of inclusion of people with intellectual and developmental disabilities appears, right? Assessment and surveillance, community partnership development, equity. I mean, these are things we've been talking about for the last couple of days, right? So this is public health, communications, emergency preparedness, accountability and performance management. If, we can say we're doing it, but if we're not measuring it, if we're not including the population in terms of evaluating how we're doing it, we're still not there, right? Policy development and support. They're not going to, this is big P and little p both in terms of that policy development support, which requires advocacy not only by the population itself, but for those of us who are supporting the advancement of our own work that's inclusive of that population. So I'm going to talk about just a few of the domains. There are 10 different domains in the FAB standards, and these are all I should probably say this so I'm not violating some copyright law. The link is at the bottom. These are all screenshots from that link, so just to give them due credit. And I'm not going to read all of these, but underlined in domain 1, the first domain that we have, which is assess and monitor population health status, factors that influence health, and community needs and assets. It says the collection and analysis of data about the health status of the community informs the identification of health disparities and factors that contribute to them in order to develop strategies that achieve equity. If we're not doing that with people with intellectual and developmental disabilities, we're not doing it, right? And so we need to be intentional about doing this. Domain 3 is about communicating effectively to inform and educate people about health factors that influence it and how to improve it. So this is the health education component of governmental public health. And domain 3 focuses on health departments' communications, which include providing information and education to encourage healthy actions. So when we talk about the work that's being done in nutrition, if we're communicating to a population with intellectual and developmental disabilities, we need to do that. I mean, that's domain 3, right? And this is that health education piece. To be effective in influencing healthy actions, health departments require communication procedures that consider sound evidence, engagement with community members during the design of messages and methods of dissemination to ensure community members are reached with actionable and understandable information, and that messages need to be designed to foster trust and transparency, considering social, cultural, and linguistic appropriateness. That's, again, if we're not doing it with people with IDD, we're not doing it, and we're not doing it. I mean, that's where we are. We're not doing it. And again, to facilitate bidirectional flow of information, communication strategies require continually strengthening relationships with partners and community members, including subgroups of the population served, like people with IDD. Communication requires authentic community engagement and dialogue with the target audiences to assure that messages are designed considering cultural humility and channels such as social media, which are capable of rapidly reaching large audiences. We're not doing this in governmental public health with people with IDD. I don't want to say universally we're not doing it. Almost all are not doing it, okay? Domain 4 is strengthening support and mobilizing community. Yes,
Can I just make a point?
please.
Because you and I got to be at the American Public Health Association, and we talked with Haley, who's doing her doctorate work.
Yep.
And she reviewed all of the community health assessments and community health
I got a
improvement
couple slides
plans.
on that.
Yeah.
Okay.
And IDD was included sometimes,
Yep.
but under mental health.
Yes, yep.
Do you want to say just?
Well, I have a couple of slides on
Okay,
that.
perfect.
Yeah, okay, all right, thank you, though. And that point I didn't have, so thank you for reminding me of that. So, yeah, so domain 4 focusing on the health department's convening and mobilizing of community partnerships and coalitions that will facilitate public health goals being accomplished, promote community resilience, and advance the improvement of the public's health. This is again one of those areas, and it's very closely, although the Community Health Improvement Plan, or CHIP, is not part of domain 4, it's part of domain 5. It relates to this. It's convening people that can inform the work we do. And this is, again, we're not doing this. We're not doing this in governmental public health. We're not convening populations with IDD or folks that serve them, or social services that provide supports, or what. We need to be doing that. And we need to be doing that because members of the community possess unique perspectives on how issues are manifested in the community, what and how the community assets can be mobilized, and what interventions will be effective. Again, if we're not involving people with IDD on the front end, on the development, on the conversation about the work we're doing, we'll be lucky at best if we get it right, and I almost guarantee we won't get it right. We don't make assumptions about other populations. We invite them to be part of the conversation. We're getting better at making sure that other portions of the population are in the room and have opportunities to inform the work we do in public health, but not the population of folks living with intellectual and developmental disabilities. Domain 5, and this is where that community health improvement plan resides within the FAB domains. It focuses on health department's ability to influence policies, plans, and laws by working across sectors with partners in the community to consider the health implications, correct historical injustices, and provide fair and just opportunities for all to achieve optimal health. That's the definition of health equity, I think. Very close to it, right? And I think it's important to point out that point about historical injustices. This is part of FAB's revisions for 2022, I think. And it's important to note, right? I mean, public health systems don't have a really good history with people with intellectual and developmental disabilities, right? Whether it's institutionalization or deinstitutionalization without plans and supports to make that work well, we've pretty much fallen down. We can point to research that's been in place for folks with intellectual and developmental disabilities, and it follows that medical model. How do we cure or prevent the IDD, right? That's not the research we need. The research we need is on social change using the social model, so we can say, how do we better change society to make it so that it works for everybody, including people with IDD. The collaborative health improvement planning process, that's the CHIP, is an opportunity for the community to determine which strategies can best leverage assets and address health needs. If we're not involving people with IDD, we're not doing it. We're just not doing it right. I think this is the last one for folks wondering when we're going to get done with the FAB standards on this. So domain 7 is contribute to an effective system that enables equitable access to the individual services and care needed to be healthy. we're still unfortunately focused on access to care. It's a huge issue. I'm not saying we shouldn't focus on it, but it's in my mind, it's access to health. Healthcare is part of that larger universe of access to health, but so are things like access to healthy food, access to opportunities to engage in physical activity, access to opportunities to engage in social connectedness. All of those are access issues. And yes, having access to healthcare once there's a problem is a good thing. But if we can have access to the other things, will prevent the number of times we need that access to care, which I've often argued is the cheapest care. If we want to bring down healthcare costs in the country, we need to invest in prevention because the cheapest care is the care not needed. And that's not preventive healthcare. We do need that. I'm not saying all healthcare. So, all right. So here are opportunities for health departments to change things. Right, the health departments will. A great deal of our time and effort is spent on community health assessments, community health improvement plans, and then the health department strategic plan. So as I said before, first thing we do is assess our environment, our circumstance, our population, the experiences of that population. Then we bring in from the community all those partners. We identify what the challenges are. We prioritize what those challenges are because we can't address everything all of the time. And so we say, well, who in our community can help us move in that direction, can help change the needle that we want to change in terms of an improvement in the population's health. That's our community health improvement plan. We identify those partners, we bring them to the table, we listen to them for who's not at the table yet, because that's usually the first thing we do wrong, is assume that we got everybody at the table we need. And then we say, well, what are y'all bringing to this conversation? And maybe it's not even at our table. Right? Remember we said yesterday, sometimes it's not bringing everybody to your table to eat the meal that you prepared. Sometimes it's being invited to their table or inviting yourself to their table and showing value when you're there. And then we come back to the health department and say, well, within our strategic plan, what did we say we're bringing to the table? And that needs to be part of our own strategic plan. That needs to be prioritized. It needs to be built into our budget because it's nothing if we're not investing in it. And so the opportunities we have to intervene here are primarily with that community health assessment and that community health improvement plan. And this is the work that I'm currently doing, that I just started doing at Special Olympics this past, seems like a year or so, but it's been about 6 months. We have a couple of projects that we're working on that address both the CHA and the CHIP. I'm not going to go through this piece again because I think we've already gotten there. Yeah, no, we're good on time. Yeah, so the community health assessment, that was the one that was in domain 1 in those FAB standards. The idea there is to really have that comprehensive picture of your community, and your community includes people with intellectual and developmental disabilities. CHAs typically don't, but we need to be able to do that. Same thing with CHIPs, the community health improvement plans. And those where you bring in those community partners and you listen to your community's voice. And we need to make sure that folks with intellectual and developmental disabilities have a voice. Again, that's a community-wide effort. All right, so this is what Meg was just talking about. There's I'm actually on our dissertation committee. There's a student at University of Eastern Tennessee University, something like that, who had just done a survey on now these are of FAB accredited health departments, right? And FAB accredited health departments that completed their community health assessment. I'm going to try to get this right, within the last 3 years, and their community health improvement plan within the last year. I think that was the universe that she was looking at. So these are high functioning health departments, right? So this is a conservative estimate. This is the best picture, right? This is the best we can hope for right now in terms of where we are, right? 0 of 346 health departments of that university included disabilities in their child demographics. All right, that's do we have a count? Do we know how many people with intellectual disabilities are in our community? That's actually not a hard number to get. It's a hard number to get precisely, but even if we just use the folks that are served by maybe the County Board of Developmental Disabilities. Maybe it's that receive Medicaid as a result of an intellectual disability. There are data points out there that we can draw from that will say it's more than this number, right? If we can say it's more than this number, then we can still make our case because it's still a pretty good sized number, all right? But 0 out of 346 health departments. Now, I take a little bit of shame in this, in that the last health department I was at was one of these health departments, okay? Part of it was we missed the timing because we had some of this in ours. 2 of the 346 health departments included a section on disabilities in general, right? So beyond the demographic count, they actually had, even though they couldn't enumerate how many people it was, they could address it in their, as a potential need, health priority in their community. 2 of 346. And if they did include it, references to disabilities and community health assessments did not typically distinguish people with intellectual and developmental disabilities from other disabilities. And we know that that experience is different for individuals. These are things that, and again, we recognize these are not individual populations. We have cross-sectionality across disabilities, but for folks who don't require a ramp, don't require Braille, don't require a sign language interpreter, they still have needs that are being unaddressed, right? So now we have a slightly smaller population within the research here. 2 of 245 identified goals within their CHIPs, right? That said, of the priorities that our health department and our community are going to address, 2 of 245 identified a goal specific to people with intellectual developmental disabilities. And 1 identified an objective or activity that the health department will engage in or the community will engage in to address one of those goals, right? So, and I will be the first to say, and this I think disappoints some folks when I say it, our goal is not really on this last 1 or 2 points, because it's still a community health improvement plan. There are priorities. They are based on size of population, size of disparity, health impact related to that disparity, and so forth. It will not always pop up, right? It's a community's decision. But if it won't pop up if we don't involve folks with intellectual and developmental disabilities in the plan, in the process, in the conversation, in the prioritization, in the giving an opportunity for self-advocacy, that this should be a priority, right? That's the point here. That's how public health works, right? We're not always going to address everything, right? That's the challenge, but we can still advocate for it even if we don't have a plan there. One of the things that was mentioned, and I don't remember, she sent me these slides a couple of days ago, and I didn't have a chance to get back and say yes, but what about? There was a number that she had there that said, for those health departments where they did include somebody, it was like 50 times greater that they would show up in the CHIP, right? So which really underscores the reason why you want to involve them in the CHA in the first place, is that if they're not involved, you're not going to have anything in the CHIP. If they are involved, you're much more likely to have it, especially if they're involved in that in your community health planning group. Yeah.
Talking,
I think you're on, just yeah.
are you talking about people with intellectual and developmental disabilities being there and or disability support organizations?
Well, and I don't know from her research if there was something that was distinguished there, right? And as is the case with populations outside of the populations with intellectual and developmental disabilities, oftentimes it's a service agency that represents a population and a community, right? I think the best practice would be that you would have both, and perhaps under different circumstances. And I mean, a well-functioning health department is going to have community partnerships that are deep, wide, and novel, right? But we'll also have those community advisory bodies, right?
And I was just going to add that my recollection of talking with Haley was that she had pretty strict inclusion exclusion criteria. So even if she found certain things,
Yeah.
it really was some social validity there. It was what we mean.
Yeah. Yeah.
So the numbers that we see here met some pretty strict inclusion criteria. So it might have been in the plan or the CHA,
Yeah.
but
It's
go
a good-
ahead.
Yeah, so this is, and this will tie back, and I don't have a slide on this one, but I actually, and I'll take the pat on the back for this one, in 2017, so 7 years ago, at the health department where I was, and this is my first interaction with Special Olympics was long before I applied for the job. We got a Special Olympics grant at the health department that we applied for this grant to do a national survey of health departments, local health, county, city health departments. And one of the questions was, are you inclusive of people with intellectual disabilities in your CHA? Are you inclusive? And I said intentionally inclusive, right? And so it was a step, a stepped survey so that it had skip patterns in it. And so if they said, yes, we're intentionally inclusive, the next question was, could you please share the strategies that you employ to be intentionally inclusive? And if their response was, we make our community health assessment process and community health improvement process generalizable enough that folks who want to can participate. Well, that's not being intentional. That's not exercising any universal design. And so then it bounced back to say, if without a strategy, we're not counting that as intentional. It's great that you think you're doing it, but we're not counting it as intentional. So the survey that I did, and it was not tied to FAB, it was very, very different. We didn't have this small of a number. We had 300 responses to a survey that went out to about 3,000 health departments. So it was a 10% response rate, which was pretty good for something like that. But we still had very few that were intentionally inclusive of people with intellectual disabilities in their CHA, in their CHIP, and we went a little bit beyond that in our survey to say, in your development of health promotion materials, in your development of a community health improvement, the planning process, and in program evaluation, right? And there's the same thing. You could say you were, but then you'd have to give us a strategy. And if you couldn't give us a strategy, then you weren't being intentional. So we did that and actually ended up being interviewed by Special Olympics International at that time and were listed on their webpage as a national champion for inclusion in public health, which I pointed out on my application when I applied for the job. They already said I was a champion, so why not hire the champion, right? So it worked out well. But this is the kind of work that we do, right? So that's the assessment. We've done the assessment. We know we're not doing it, right? So what was it we're gonna do, right? That assessment piece, right? We get it. We're not doing it, so then what? We've got two projects that we're doing right now that I made reference to. One is working with, and for a variety of strategic reasons, we're focused on health departments in the 6 states that make up Health and Human Services Region 5. It's the Great Lakes states. Part of it, I met with well, I don't know how long he'll be the director of HHS Region 5, but he's currently the director of HHS Region 5, who was very interested in the application of this work. And frankly, if you want to get something changed on the massive system level, you need the federal government involvement in doing that. And so we wanted to bring him early. So I brought him, I think I was working there for about a month, and I went up to Chicago and met with him about this project. So we're involving, and I always do this. I say I was going to list the name of the states: Ohio, Indiana, Illinois, Michigan, Wisconsin, and Minnesota. And Indiana. I knew I was going to miss one, right? So we have those 6 states. And what we're doing is we're reaching out within those 6 states. We're identifying 4 local health department teams. A local health department team consists of the person that's ultimately responsible for the development of their CHA, the person that would do it if that person stopped coming to work, which usually is the health commissioner, or if it's a robust health department, they may have another person that does it, and then 2 community members, right? And we told them that the plan for their team was to help brainstorm, come up with, devise a strategy or 2 that they think might work to help them collect information, consistent with other information collected in their CHA, but specific to populations with intellectual and developmental disabilities, right? Wasn't that they had to have it. They wanted to commit to developing a strategy, right? It was very clear, you don't need to, we don't want you to rewrite your CHA, right? Because nobody's going to volunteer to participate. But we want you to commit to that. So the health departments would identify 2 community partners. So in each of the 6 states, we're bringing those those teams to a single meeting within that state for a 3-hour guided conversation. We've so far only done this in Ohio because I know lots of health commissioners in Ohio, and so I knew which ones to ask that would say yes. And so we had those teams, and then we just went through a process of a dialogue for about 3 hours to talk about their CHA, to talk about their community, to talk about the population that they serve with intellectual and developmental disabilities, to talk about the resources that they might have that others might not have in terms of their community partners, in terms of other governmental agencies, in terms of service providers, in terms of self-advocates. I mean, any of this that they can bring to the table. And we talked about what sort of information do they want, right? And do we want data that is drawn from the same survey that we use in general, from the Behavior Risk Factor Surveillance Survey, from the American Community Survey? What types of information do they want? And these are community specific. This isn't, we're going to have the perfect master list that everybody's going to do, right? There's a reason that these are done on the community level. And they need to be relatable to the community, or we're fighting an uphill battle already, right? So in Ohio, we did this. Everybody came up with, at least one strategy for their community. Then what the task is, they need to go back and field test that strategy. Again, very, very open expectation. If you identified other community partners that were going to be involved in it, give them a call, pitch it to them. Do they have the time, energy, inclination to participate in that strategy? Think about any type of regulatory issues you may have in terms of data security, of and any number of things that could pop up. Then go back and give it a shot. All right. So we've done, Ohio worked like a charm because it was there. Minnesota, I tried to do it a little too quickly because I tried to tie it in with the APHA conference and didn't quite give myself enough lead time. But I worked the halls at APHA and we ended up meeting with 3 different health departments. It wasn't at the same time, so it was a little off standard of our plan, but we got them. And then I think it's December 9th. A colleague and I will drive up to Grand Rapids, or I'm sorry, Lansing in Michigan to have that conversation there. We have already got our 4 health departments lined up there and a couple that wanted that we might just sort of invite in anyway. Again, to go through that same process. They're going to identify strategies that work for them. They're going to field test them. They're going to tweak them. They're going to change them. I don't care what they do to them, because the idea is then in May, we're going to bring one person from each of those health departments to Special Olympics headquarters to debrief and to try to identify 1, 2, 3 best or promising or tested practices, and then try to help disseminate those. All right. So this is just how we try to operationalize this. We're approaching with the humility to go, it will probably not look the way we designed it. And that's okay, because then we'll adjust. We'll take another year of funding next year and expand it. We'll get there. But we have to get there by being wrong first, and then we'll be right. And that's sort of just the approach of public health. All right. So that's one. That's the CHA. The CHIP, we've approached it a little bit differently. Before I got to Special Olympics, they decided that, well, we'll just work with our Special Olympics state programs and say, one of the grant deliverables, if you want this, $150,000 or $180,000, grant for the year, is that you're going to start a community health coalition in your community that's inclusive of people with IDD. Well, I love our health staff. Most of them have no idea what that meant, right? They're running the health screenings. They're doing family health forums. Their community coalition building is probably not within a lot of their wheelhouses. Some of them, yeah, got it, not a problem. So anyway, a lot of folks kind of crashed and burned on that one. And so they went out, they really just weren't sure what they were doing, what it meant and all of that. So then this year, what we've decided to do, and this is where I'm going next week, is back down to DC, because we're bringing in programs, SO programs that tried it or are interested in it, but may not have been successful in doing it. And we're going to do a training on what it means to have a community coalition. right? And through this training and prepping the local Special Olympics at the local level, my guidance is to reach out to your local health department because they already have a community health coalition. It's called a CHIP, and bring yourself to the table. Again, I said it yesterday, I'll say it again today. We should not be designing a parallel system to fix a problem that's in a national system that's just not inclusive. We should be working with the national system to make it inclusive and then move on to the next thing that we do, right? So if a health department has a community health coalition, I'm encouraging our Special Olympics folks to reach out to the health department. Bring your healthy athlete that's been trained as a self-advocate. Bring your any of the folks that are comfortable to that conversation. Bring their a caregiver if they have a caregiver. Bring a service organization if they're in a group home that has a service provider. Whatever it may be. Let's make sure that those community coalitions are inclusive, right? So that's our step there. And because, you know, even before you get the first work done, you're thinking ahead about the next one. We do have a couple of things that I want to do next year, or the year after, or the year after that. I'm not going anywhere just yet. But hospital systems community health needs assessment. They're called China's. They're just the same thing as a CHA. They should be happening in concert with the CHA, and they typically don't. So what we're going to try to do is take the model that we're using with local health departments on their community health assessment, export it to health systems, so that when they do their community health needs assessment, as most hospital systems do if they want their IRS tax status, they have to do a community health needs assessment every 3 years. We want to make sure that those are inclusive as well. All right, so we're going to take lessons learned from the government health departments and apply it to the hospital systems. And then again, another one that I want to do is to take the lessons learned here with governmental public health and say public health department emergency preparedness planning, right? Every time we have them with greater frequency, every time we have an emergency in a community and we have a public health emergency response, and we do a debriefing afterwards. We do the hot wash. We do that. What did we do right? What did we do wrong? Invariably, one of the things that we don't say we did it wrong. One of the things we have an opportunity for improvement on is reaching populations with disabilities, right? Horror stories out of Katrina, right? We haven't fixed the problem yet. And part of it is the acute nature of emergency response. And even if the response is going on, I mean, we've stopped talking about the hurricanes in Tennessee and North Carolina. We've certainly stopped talking about Katrina, although if you go down to New Orleans, you could still see communities that have not been serviced yet, repaired yet. The attention span for emergency preparedness is very short. And so I think that we give ourselves an out by saying we'll figure it out by the next one, but we never do. Right. So this is again one of those opportunities where I think if we talk to folks with lived experience, we might learn something in terms of how we might better approach communication, information dissemination, understanding what the needs are in an emergency, depending on the kind of emergency, understanding what the supports are and what happens when those support systems are also trying to deal with an emergency with their own, at home. What happens during COVID when your service providers that work at that group home have families they need to take care of, who's staffing the group home or the residential home. I have a sister and I don't call it a group home because she has got a roommate but they do have staff. So what do we do about that? I was talking with a colleague this morning from Geneva, and she was saying because I told her what my plan was that I'm going to put in for our grant to CDC next year, and this is the kind of work that I'll put in. And she said, we just had a conversation with folks at the International Red Cross and Red Crescent Society, the international version of American Red Cross, and they were talking about this. And so it's one of those that it reminded me of the things that I keep saying, that we can't do everything. We need to find the folks that are doing it and help them do it better. Well, if public health can't figure out emergency preparedness, it's inclusive of people with IDD. Maybe we work with the folks at Red Cross who already figured out the emergency preparedness response in terms of that immediate response, and say, how can we help them do their job in an inclusive way, right? So lots of ways to get there. We don't need to be on the point of the spear all the time, right? Sometimes we need to be on the handle, and that's okay. So don't really like that analogy as a pacifist, but it's a spear. It works. Okay. So anyway, thank you. Do you have any questions that I might try to answer? I didn't get my time.
Great.
I figured you were going to ask something.
Hey,
Yeah.
so I feel like I don't have like a clear question because what? Oh, hi, I'm Katie Stone. I'm from the National Association of Chronic Disease Directors. I'm a white female with blonde hair that's pulled back with glasses on, sitting in a chair, super anxious because this is making me feel anxious. I feel like I don't have a clear question because there's so many layers, as we were saying. But I've been kind of reading about like an ecosystem of health, right? Because it's like you have all these departments. So you have the Department of Education, you have the Department of Transportation, you have the Department of Aging, you have the Department of Health, you have all the departments. And it's like they're all working in silos. And until they're all working in an ecosystem together towards common goals, it's so time consuming and resource heavy to always be in the room and to think about all the things. So I don't know the answer, but like it's just not efficient and it's very frustrating. An example I'll give is, and I think this is in a lot of health departments, in Columbus Public Health, we house the transportation, like one of the transportation experts in public health, so that they are always voicing the concern of health in regards to transportation. So they're always at the table and they're regarded as the expert in public health and in transportation. But it's like, how do we do that with all of the other things to consider, all of the other departments? Again, I gave this example earlier. I worked for the Department of Aging, and one of their biggest campaigns in Ohio is the 10 million steps, which isn't inclusive. So then they would throw some videos online where if you couldn't step, you could do these other random things, but it wasn't very good. But I don't know. I'm frustrated, but like what you're saying is really great, but I wish that we could like make it more efficient and I don't know.
Yeah, I will tell you, it's not efficient. It's not going to be efficient.
Great.
It would be a lovely thing. What a wonderful world it would be, right? But what we can do is we can say, well, what can we do? And that's typically, the answer is almost always at the grassroots level. It's at the community level. And it's saying, are we going to be led by, a national department or, a federal department? Are we going to be able to be more flexible and more adaptive within our own community using, whoever we have that's a stand-in from that type of work, transportation, or whatever it may be.
Tom, can
Yeah.
I prompt you just because I heard and I heard Mary Casey Locker's from the Red Cross voice in my head. Can you just talk a little bit about One Health as a movement? And in terms of
I'm going to ask you too, because I'm not well versed on One Health.
Okay, so I'll just say you're absolutely right. And all of these silos have to break down in disaster response. And so Red Cross is really trying to move towards what's a movement that really started with veterinary science, where they're often like on the sidelines, but their role in terms of our response at the community health level is so critical to doing things well. And so they've started to say, we need to think about the planet, we need to think about climate change, we need to think about the animals and the humans and the community. And so it is this intentional approach within public health to be talking about One Health and bringing all the domains together to say where are our opportunities to do better together, just in a synopsis.
Yeah, no, I think, and I'll add a nuance to that I think we bounce back and forth.
Yeah.
Because oftentimes if everything is something, then we lose the specificity to do anything with it. Right? We lose the edges, we lose the nuances of the thing that we're talking about. So I think the conversation is that global in nature in terms that, well, social determinants of health, right? But I still think it's the action happens at that unit level, but depends on communication, depends on an overarching philosophy or mission or direction. or resourcing, funding. But yeah, it's bouncing back and forth between the macro and the micro, grassroots, grass tops, et cetera.
This is Mackenzie Jones with the Montana Disability and Health Program. Thank you for your presentation. I had a question about the CHA and then follow up about the CHIP. So the county health assessment, when we do include people with IDD or people with disability, what data is leading to objectives in the community health improvement plan?
So I can give you the example that I had when we did this in one of the health, Marion, I think it was Marion County. Our and it's often the case, and we sometimes forget to go there because it seems like it's too much of a concession. But I think our goal, our strategy, something, our objective, one of that nomenclature in planning in Marion County was actually to identify sources of information. I mean, that was a goal in our community health improvement plan as it related to people with intellectual and developmental disabilities. Was what's our plan for actually collecting information that feeds into the CHA that will let us know if we've moved the needle in terms of our health promotion or disease prevention efforts with regard to that population. If we don't have data, I mean, that's why we start with data, right? And sometimes the goal in your plan is to find out how to get data. So I mean, it seems like a punt, but if you don't have it, you don't have it, and that's the first thing you need to do is go back and get it.
Thank you. I worked on the Montana State Health Assessment and State Health Improvement Plan design team, and we had the data, and it often came out as, well, everyone is experiencing disparities in these areas around chronic disease, around childhood ACE scores, which stands for, I forget.
Adverse childhood events.
Adverse childhood experiences, around, thank you for the chorus. Safe driving. And so the data ended up minimizing the specific priorities of people with disability because they still had those disparities and they still are priorities to the population, but maybe not as important as transportation or access to community living. And so then that leads into my question about health improvement plans and if their voice is being overshadowed by a disparity that's louder, by the larger population, how do we get specific goals into the improvement plan that really do focus on the specific priorities of this population?
Yeah, and so you use the word specific a number of times there. And at the state level, you're not going to get specificity for any population because you're talking about a state. In a community level, and even at a county level, you know, it could be tough. In a neighborhood level, maybe, right? But this is where, again, we bounce back and forth between recognizing that we need a community health improvement plan and that we need more than a community health improvement plan. The community health improvement plan isn't the end all be all. It's not the only thing we do. That's where we depend again on those community partners where that is a priority, where that specific thing is a priority. We recognize it with the data that maybe something might not make it into the community health improvement plan, but if that data is collected at the community health assessment, then whatever agency, whatever body, whatever advocacy group, whatever, you know, neighborhood advocacy body will have data then that they can use, that they can continue that fight towards, that they can continue to seek resources to fund that work. You can't, trying to get resources to fund work depends on data. It just does. I mean, there, you know, very few benefactors out there are mission oriented. There are some, and that's great. But if you want to get the dollars to you know, support programming, then you need that data. So yeah, it's a kind of a sucky answer, but it's.
And this is Lindsay from Kentucky. It was a great question, Mackenzie, and a great answer, Tom, that really the data informs the work is so important. And so I just wanted to share something that we've been working on in Kentucky was infiltrating our state health improvement plan. So attending the big meeting at our state capitol, there was one colleague and I, we were the only 2 disability representatives, and we made sure that our voice was very, very loud at every point of that meeting. And then once the work groups were decided upon for the focus of there's a nutrition work group and a substance use, we made sure that there was people from our team represented across every single one of those work groups that served in leadership roles, that had that voice to make sure that when the goals and the objectives were developed for each of those work groups, the disability data was our #1 objective, to make sure that we were including that and asking the questions as a part of that, but also making sure that when those broad goals and objectives were written, something about health equity, or if we could include the word disability, if there was a list of vulnerable populations, some way, somewhere, disability is represented. And this is our first time within our SHIP that we feel like we've accomplished that, because it was a collective effort of making sure to put in that time and effort. But what I think is something that we mentioned earlier, we had a side conversation, is, but all of that effort that's not funded effort on our part, but we're having to put in the work to lay that foundation to hopefully then get those goals and objectives written so that it does include disability. So then when the data shows how much important that is, then we can start using that to find the funding. Just wanted to share that.
It's that first step of going from lack of awareness to awareness, right? I mean, folks are not aware in general, the folks that are doing the work, unless they're folks like everyone in the room, aren't aware that there's an issue there. It's a largely invisible population unless we are intentional in our advocacy, and frankly even annoying in our advocacy. If you're omnipresent in those work groups, and I think that is what's needed, right? If you're one voice in a room of 100, you may not be heard. If you're one voice in 10 rooms of 10,
We gotta wrap up.
you're there, and it's still 100 people.
One more question, then we've got to wrap up, have a quick break, and get ready for our breakout sessions. Just so folks know, there's going to be a breakout session here on inclusive and accessible gardening. And then the other breakout session is in 333, and it's on inclusive and accessible cooking classes and education. So really excited about both of those. Yes, last question.
Actually, you set me up perfectly for my question. My name is Angela. I'm with the Montana Office of Rural Health and Area Health Education Center. And my question is one of the things that our office does is it collaborates to do CHIPS and CHAS. And my question was, a lot of times what we see is that community health implementation plan gets created and then it just sits there. It's a little bit like a nonprofit creating a strategic plan that we put a lot of effort into it and thought into it, and then it just sits and nothing happens. And I think I heard you say that if we include, if we're more inclusive in these, there's 50% more likelihood that they'll show up in the CHIP. And so I was wondering, could you speak to, does that create, is that more of a catalyst? Do you see more activation in the CHIP when there is more representation? Does it have more power and more action that people get behind, and there is actually actionable things?
I would love to say I see that. I can't say I see that because, we don't know yet, right? I would say that there's great logic behind that. I think that we probably see that with other examples, none of which I can think of right now. But yeah, if you're part of the plan, if there's an objective in that plan should be something where the community can then hold the health department and the other community partners accountable, right? It's here. What have you done, right? The other piece, again, going back to FAB, is the FAB guidance on CHIPS is not that it's one and done, is that you have ongoing monthly or quarterly or bi-monthly meetings where you're updating it, where you're checking in, where you have new data, where that data is then shared back out with the community. And this is where I really think that even though it may be inherently part of the mission of public health. We don't always do things because we get busy and we do those plans and they sit on the shelf. But if we can have folks in that community and that the jurisdiction of that health department that has that community health improvement plan and they show up at a board meeting, board of health meeting, and say, hey, we haven't heard how's that community health improvement plan going? Specifically, I'm interested in yada, yada, yada. Right? That's how that happens. That's all part of that advocacy.
Love it. Great comments. I just want to take a point of privilege and celebrate Missoula City County Health Department, who now has a community living goal. So the data that were influential is talking about when you look at people who do not live in the community, who live in institutions, how many have disabilities. It's mostly people with disabilities in our prisons. It's all people with disabilities in our nursing homes and in our larger congregate settings. And those are the people who are at highest risk during COVID and were most likely to die. So in that moment, we were able to bring forward those data. We have a plan, right, Olmstead plan in the state to support community living, and we were able to center it within our community health improvement plan in that moment with advocates being there. And so just wanted to take that point of privilege and celebrate that. I know there's other things to celebrate in Montana from the work of our health departments that we can lift up into the wonderful work you're leading, Tom, at Special Olympics. I'm so excited about your presentation and your leadership and the partners that you're engaging. Big round of applause for Tom.